Our next topic is endodontic access cavity preparation. So, what is access cavity preparation? It is defined as, according to the Stephen Cohen, it is defined as the part of preparation from the occlusal table to the root canal orifice. Or endodontic, it is defined as endodontic coronal preparation that enables unobstructed access to the canal orifice, that is, a straight line access to the apical foramen, complete control over the instrumentation, and accommodate obturation technique. So, what are the objectives of access cavity preparation? Proper coronal access forms the foundation of the pyramid of the endodontic treatment. According to Walton, there should be straight line access. So, there should be a straight line access to the apical foramen. There should be improved instrument control, improved obturation, and a decreased procedure errors. So the main objective of access cavity is the conservation of the tooth structure. There should be minimal weakening of the tooth and prevention of the perforation. So the objective of entry is to give direct access to the apical foramen, not merely the canal orifice. The internal anatomy of the tooth under the treatment must be determined. When the canals are difficult to find, the rubber dam should not be placed until the correct location has been confirmed. So there should be unroofing the chambers and exposure of the pulp horns. So as the part of access preparation, the unspotted cusp of the posterior teeth that must be reduced. The endodontic entries are prepared through the occlusal or the lingual surface and never through the proximal or the gingival surface. A preoperative periapical radiograph, it is a must prior to the access cavity preparation. Why radiograph is important? It will tell us about a radiograph will tell us about the morphology of the tooth, anatomy of the root canal system, number and the length of canals, branching of canal system, position and depth of the pulp chamber. Also, we can locate the position of the apical foramen as well as calcification or any resorption that is present. The Engel divided the access cavity preparation into two parts. That is, the first is the coronal preparation. This one is the coronal preparation and the radicular preparation. What are the phases of the access cavity preparation? There are the three phases of the access cavity preparation. The first is the penetration, second enlarging, and third is the finishing. So this one is the penetration, D is the enlarging, and third is the finishing. What instruments do we need for the access cavity preparation? We need access opening burrs. They are round burrs with 16 mm burr shank. They can be 3 mm longer than the standard burrs. We can also use as the access refining burrs. These are the access refining burrs. These are coarse grit flame shaped or can be tapered round for refining the walls of access cavity preparation. Other burrs that can be used are the Molar burrs and the Munset discovery burrs. The Molar burr, they are long shaft round carbide tipped burr that are used with the low speed handpiece. So they are used for locating calcified canals because their long shaft is useful for working deep in the radicular portion. Similarly are the Munset discovery burr. They are long round carbide tipped troughing burr with stiff shaft that are 1 mm in the diameter. So these burrs are used for safely locating calcified canals and exposing separated instruments deep within the radicular structures. Generally we can get a kit containing the access cavity burrs that consist of two carbide round burrs, one diamond round burrs, one transmetal burr, gates, cleat and drill. So what are the principles of the access cavity preparation? There are the four principles. Number one is the outline form, second convenience form, third removal of the remaining carious dentine and defective restoration, and last is the toilet of the cavity. The first is the outline form. It is established by mechanically projecting the internal anatomy to the external surface. So the three factors that regulate the outline form are the size of the pulp chamber, shape of the pulp chamber, and number and direction of the root canals. So in the young patient, what you will see is the access preparation is wider than the older ones. The shape of pulp chamber, the final outline should reflect the shape of the pulp chamber. It is triangular in anteriors, ovoid, buccolingually in the premolars, and trapezoid or triangular in the molar. And last is the shape of pulp chamber. It can be determined by the number, position and curvature of the canal. Now before starting the access cavity preparation, one should check the depth of preparation by aligning the burr and handpiece against the radiograph. So this is done as to note the position and depth of the pulp chamber. So place a safe end burr in the handpiece. Complete the outline form. So the burr is penetrated into the crown until the roof of pulp chamber is penetrated. A round-ended carbide burr that is used for the access opening. So what you feel is sometimes you will feel a tactile sense or drop-in sensation is felt to the pulp chamber. So once a drop-in is into the pulp chamber is obtained, burr is moved inside to outside. So you will move the burr from inside to the outside. Access finishing, it is best carried out by using burrs with shaped non-cutting edge. So the advantages of these burrs are they are less likely to damage or perforate the pulp chamber floor, as these burrs will cut in the lateral direction, so these cannot drop into the small canal orifice. So if the pulp chamber it is not completely de-roofed, it can result in the contamination of the pulp space or discoloration of the endodontic treated tooth. The walls of the pulp chamber, they will be flared and tapered to form a funnel shape with a large diameter toward the occlusal surface. So once you feel a dropout in the pulp chamber, you will replace the round burr with the tapered fissure burr. Avoid using flat-ended burrs as that results in irregular access walls and may cause multiple ledges. So there are law of relationship of the pulp chamber to the clinical crown. They are the relation of pulp chamber to the clinical crown. They are law of centrality, law of concentricity, and law of the cemento-enamel junction. There are law of relationship of pulp chamber to the canal orifice. They are law of symmetry, law of color change, and law of orifice location. According to the law of orifice location, the orifice of root canal, they are always located at the junction of the walls and the floor. The orifice of root canals, they are located at the angle in the floor wall junction. And the orifice of root canal, they are located at the terminus of the root development fusion lines. Now let us discuss the laws of access cavity preparation for locating canal orifice. The first is the law of centrality. According to the law of centrality, the floor of pulp chamber, it is always located in the center of the tooth. Suppose this is the this is the tooth, and this is the floor of the pulp chamber. So the floor, it will be located in the center of the tooth at the level of the cemento-enamel junction. Second is the law of the cemento-enamel junction, that states that the distance from the external surface of the clinical crown to the wall of the pulp chamber, it is same throughout the tooth circumference at the level of cemento-enamel junction. So the distance from the external surface of the clinical crown to the wall of the pulp chamber is the same throughout the tooth. Third is the law of the concentricity. It states that the wall of the pulp chamber, they are concentric to the external surface of the tooth. So the external tooth surface will reflect the anatomy of the pulp chamber. So if there is a concavity in the external surface of the tooth surface, a similar concavity will be seen at the pulp chambers, at the wall of the pulp chambers. So the wall of the pulp chamber, they are always concentric to the external surface of the tooth at the level of the cemento-enamel junction. Next is the law of the color change. The color of the pulp chamber, the color of the pulp chamber floor, it is darker than the cavity walls. Law of symmetry, it states that the canal orifice, they are equidistant from the line drawn in the mesial and distal direction through the floor of the pulp chamber. And law of orifice location, the canal orifice, they are located at the junction of the floor and walls at the terminus of root development fusion lines. Now let us discuss the SS cavity of the anterior teeth. The SS opening, it is initiated at the center of the lingual surface. So you need a round burr for the SS cavity preparation, that is adjusted at perpendicular to the lingual surface at the center to penetrate the enamel. So once the enamel is penetrated, the burr is directed parallel to the long axis of tooth until a drop in effect is felt. Now when the pulp chamber has been penetrated, the remaining of the chamber roof, it is removed by working the round burr from inside to outside direction. So this is done to remove all the obstruction of the enamel and dentine overhangs that would entrap debris, tissues and other material. Now you can explore and locate the canal orifice using an endodontic explorer. So check for the canal orifice if there are any calcific deposit, and also check the straight line access to the apical foramen. So once the canal orifice they are located, you can remove the lingual shoulder either using a GG drill or safe tip diamond or carbide burr. So lingual shoulder, it is a prominence of dentine that is formed by removal of the lingual roof that extends from the cingulum to 2 mm apical to the orifice. So during the removal of the lingual shoulder, the orifice should be flared. So by this, a straight line access to the apical foramen is obtained. The outline form of the SS cavity of the maxillary central incisor, it is a rounded triangular shape with the base facing the incisal aspect. The shape, it may change from triangular to slightly oval in mature tooth because of less prominence of mesial and distal pulp horns. For the maxillary incisor, the shape of SS cavity, it is similar as that of maxillary central incisor, except it is smaller in shape. And when the pulp horns they are present, the shape is rounded triangle, and if the pulp horns they are missing, then the shape is oval. Since the maxillary canine they have no pulp horns, the SS cavity is oval in shape with greater diameter being the labiopalatally. For the mandibular incisor, the access cavity of mandibular central and lateral incisors it's almost similar. The shape is long oval with greater dimension incisogingivally. The shape of access opening is similar to for the mandibular canine. It is similar to maxillary canine, that is oval but smaller in size. The root canal outline is narrower in mesiodistal dimension. Two canals may be present. So there may be few errors in the endodontic access openings. Errors occur when the operator fails to excavate and identify all the caries and remove the unspotted weak tooth structure or faulty restoration and establish a proper, or while error occurs due to failure to establish proper access to the pulp chambers space and root canal system. And when the operator fails to identify the angle of crown to the root and angle of tooth in the dental arch. So for the maxillary first premolar, the access cavity is oval shape. The two pulp horns, they are situated just within the peak of their cusp. The orifice of two canals are also slightly more within the horns, so one can prepare a good access cavity without involving the cusp. So this one is the access cavity for the maxillary second premolars. In the mandibular first premolar, what you will see is there will be presence of 30-degree lingual inclination of crown to the root. So the starting point of the burr should be halfway up to the lingual inclines of the buccal cusp. That is important that you have to remember while preparing the access cavity for the mandibular first premolar. The access cavity for the mandibular second premolar, it is similar to mandibular first premolar. The enamel penetration is initiated in central groove due to the small lingual tilt. What is mouse hole effect? A mouse hole effect is defined as the extension of orifice to the axial wall that results in the mouse hole effect. It occurs because of under extension of the access cavity that results in the hindrance to the straight line access cavity that may cause further procedural errors. So this figure represents the mouse hole effect. What you will see is due to the under extension of the axial wall, what you will see the orifice opening appears partly in the axial wall, this axial wall, and this appears partly in the floor. So that results in mouse hole effect. Option B, this figure represents the correct opening. Now let us discuss the access cavity preparation for the maxillary first molar. The shape of pulp chamber, it is rhomboid in nature. The palatal canal orifice, they are located palatally. The mesiobuccal canal orifice, they are located under the mesiobuccal cusp. The distobuccal canal orifice, they are located slightly distal and palatal to the mesiobuccal orifice. So a line drawn to connect all three orifices that will form a triangle that is known as molar triangle. A second mesiobuccal canal is present. Stropko reported finding two canals in 73% of the first molars before using the microscope and 93 after after using the microscope. The mean distance of the mesiobuccal 2 orifice from the mesiobuccal 1 orifice was 2.3 mm. The distance between the MB1 and MB2 was on average 1.82 mm, and the orifice was to the lingual of the MB1. The MB2 orifice can be sometimes be found close or even in the palatal canal orifice. In the case of maxillary second molars, MB2 less likely to be present. Three canals that forms rounded triangle with base toward the buccal side. The mesiobuccal orifice, it is located more toward the mesial and buccal than the first molar. The access cavity for the maxillary third molars. 50% of the third maxillary molars, they had three separated roots, of which 45% had two or more canals in the mesiobuccal root. About 40% have fused roots, 2% have C-shaped canals, 2% had four separate roots. For the mandibular first molars, the mesiobuccal orifice, it is under the mesiobuccal cusp. The mesiolingual orifice is located in depression formed by mesial and the lingual walls. The distal orifice is oval in shape with large diameter buccolingually and located distal to the buccal groove. The shape of access cavity, it is usually trapezoidal, rhomboid, irrespective of number of the canal present. The access cavity for the mandibular second molar, it is started from the central fossa and it is created according to same rules used for the first molar. Because of the slight distal angulation of its root, the access cavity can however be less extensive in this case. The shape of access cavity depends upon whether there is 1, 2, 3 or 4 canals that may be round, oval, triangular or quadrangular. There may be errors of access preparation in the lower molars. The access preparation may be overextended. There may be perforation into the furcation area or failure to find a second distal canal, ledge formation caused by faulty exploration and using a too large of an instrument. Many times straight line access leads to severe loss of tooth structure, so that may be required for the strength of the crown. At least 2 mm of the dentine thickness should be present between the external tooth surface and the endodontic access at the finish line. An area of 4 mm above and below crustal bone, it is important for ferrule, strength of the tooth in the cervical area. So it should be always conserved maximally. The GG drills, they are non-end cutting and are self-centering, so care must be taken to avoid strip perforation or overcutting at the furcation area. The pulp chambers should not be completely de-roofed. Some of the roof is preserved all around the periphery of the tooth, that is also known as soffit, that is done to avoid damage to the lateral walls. What is radiax entomolaris? It is presence of additional distolingual root in the mandibular molars. That is extra root that is present on the lingual side, whereas radiax paramolaris, it is the presence of additional distobuccal root in the mandibular molars, that is the extra root that is present on the buccal side. In the case with the calcified canals, the use of magnification and translumination as well as the color change and the pulp chamber shape dyes test should be used. The calcified dentine that may be slowly removed using ultrasonic tips. Angled direction radiograph can be used. A small K file coated with the chelating agent can be used. In case with the crowded teeth, conventional access cavity may not be possible. Instead, a buccal assessed preparation that may be the treatment of the choice. So, in the crowded teeth, the assessed preparation may be instead of the conventional assessed preparation, we may use buccal assessed preparation.